नमस्कार दोस्तों। एक सीधा सवाल दिल से पूछता हूँ। क्या आपके घर में कोई है जो हमेशा थका रहता है, जॉइंट्स में दर्द रहता है, कभी कभी बुखार आता है बिना वजह के, चीक्स पे अजीब सा रैश आता है बिना वजह के, कोई क्लियर आंसर नहीं मिलता? तो दोस्तों, आज का ये लाइव उसी इंसान के लिए है। आज हम बात करेंगे एक ऐसी डिजीज की जिसे मेडिकल साइंस में द ग्रेट इमिटेटर कहा जाता है, क्योंकि ये 100 चेहरों में आती है और डॉक्टर भी कंफ्यूज हो जाते हैं। इसका नाम है एसएलई यानी सिस्टमिक ल्यूपस एरिथमेटोसिस। और इस टॉपिक पे गाइडेंस देने के लिए आज हमारे साथ हैं एक बहुत ही खास डॉक्टर, जिनसे मैं आपको अभी मिलवाता हूँ। दोस्तों, आज हमारे साथ स्पेशल गेस्ट हैं डॉक्टर विश्व प्रकाश तिवारी जी। इन्होंने एमबीबीएस और एमडी के बाद डीएम इन क्लिनिकल इम्यूनोलॉजी और रूमेटोलॉजी की है। ये इंडिया की सबसे स्पेशलाइज्ड मेडिकल डिग्रीज में से एक है। इस फील्ड के डॉक्टर पूरे देश में बहुत कम हैं, और हमारे उत्तराखंड में डॉक्टर साहब जैसों का होना हमारे लिए एक बहुत बड़ी बात है। फिलहाल डॉक्टर साहब एसएमआईएच हॉस्पिटल में प्रैक्टिस करते हैं और एसजीआरआर मेडिकल कॉलेज देहरादून में असिस्टेंट प्रोफेसर हैं। मतलब ये सिर्फ पेशेंट ठीक नहीं करते, कल के डॉक्टर्स को भी ट्रेन करते हैं। डॉक्टर साहब, आपका इस लाइफ में दिल से स्वागत करता हूं। दोस्तों, आज डॉक्टर साहब अपनी स्लाइड्स के थ्रू आपको एसएलई के बारे में पूरी जानकारी देंगे। उसके बाद मैं उनसे कुछ इंपॉर्टेंट सवाल करूंगा और फिर हम क्लोज करेंगे। तो बिना किसी देर के डॉक्टर साहब, फ्लोर आपका है।
थैंक यू डॉक्टर अंकित। टुमारो इज अ वर्ल्ड एसिली डे। कल हम जो 10 मई है उसको वर्ल्ड एसिली डे के रूप में हम उसको अवेयरनेस के रूप में मनाते हैं। सेलिब्रेट बोलना अच्छा वर्ड नहीं है, बिकॉज एसिली इज नॉट अ डिसीज टू सेलिब्रेट। इट्स अ डिसीज टू ऑब्जर्व एंड फॉर टू क्रिएट अवेयरनेस। सो उसका थीम भी है, मेक एसिली विजिबल। सो आई विल ट्राई टू कवर इट फॉर द जनरल पेशेंट प्रोस्पेक्टिव। और कुछ हमारे मेडिकल फैटर्निटी के लोग भी होंगे तो उनको भी एक रफ आइडिया देने के लिए कि एक्चुअली एक्चुअल में होती क्या है और प्रोसीड कैसे करती है। ठीक है, तो कैन यू सी माय स्लाइड्स? ओके, आई एम ऑडिबल? हेलो?
यस सर, यस सर, इट्स विजिबल सर, योर स्लाइड्स आर विजिबल।
आई एम ऑडिबल ऑल्सो?
यस सर, you're audible sir. Good to go.
ओके, तो लेट्स डिस्कस लूपस। तो लूपस में सिस्टेमिक लूपस एरिथेमेटोसिस, एसएलई। एसएलई एक ऐसा, हिंदी लैंग्वेज में कोई इसका शब्द नहीं है, जैसे डायबिटीज में मधुमेह कहते हैं, है ना। हाइपरटेंशन में आप उच्च रक्तचाप बोल सकते हो। ठीक है, अलग अलग। तो यहाँ पे केवल गठिया बोल दिया जाता है। तो गठिया और वात में अगर आप मेरे से पूछोगे तो वात को मैं ज्यादा परफेक्ट लूंगा, क्योंकि ये एक ऐसी बीमारी है जिसमें आपका इम्यून सिस्टम, आपका जो प्रतिरोधक तंत्र है, जो नॉर्मली डिजाइन किया गया है बैक्टीरिया, वायरस, फंगस या कोई भी टाइप के पैथोजन है या फिर कीटाणु है जो हमारे शरीर पे बाहर से अटैक कर सकते हैं, उनसे फाइट करने के लिए। ओके, तो इसके दो स्पेक्ट्रम समझ सकते हैं। जब हमारा इम्यून सिस्टम पूरी तरीके से खराब हो जाता है तो ऐसी उपलब्ध बीमारियों में एक बीमारी है जिसे एचआईवी कहते, एचआईवी नहीं, एड्स कहना चाहिए, एक्वायर्ड इम्यूनो डिफिशियंसी डिसऑर्डर। इसमें आपका इम्यून सिस्टम पूरी तरीके से खराब हो जाता है। आपको वेरियस प्रकार के स्किन की प्रॉब्लम, जॉइंट की प्रॉब्लम, लंग्स की प्रॉब्लम, किडनी की प्रॉब्लम, हार्ट की प्रॉब्लम होना स्टार्ट हो जाती है, क्योंकि आपका इम्यून सिस्टम काम नहीं कर रहा हो। एग्जैक्टली अपोजिट स्पेक्ट्रम में टिल नाउ के हिसाब से अगर आप डालेंगे तो रफली अपन 180 डिग्री पे अगर बोलें कि इम्यून सिस्टम बहुत तेजी से अगर ऑन हो जाता है, तो ऐसे ही मल्टीपल सिस्टम को इन्वॉल्व कर लेता है, जिसका एक प्रोटोटाइप बीमारी है एसएलई, सिस्टेमिक लूपस एरिथेमेटोसिस। तो एरिथेमेटोसिस क्यों? ये सबसे पहले ये स्किन से मैनिफेस्ट कर रही थी, तो सबसे पहले स्किन को ही पकड़ा गया। तो रेड कलर के चीक्स में कुछ निशान आते थे, त्वचा में निशान आते थे, तो उसको एरिथेमेटोसिस बोला गया, मतलब रेड कलर के निशान। फिर लूपस का क्या मतलब है? लूपस का मतलब क्या होता है? वुल्फ बाइट। तो स्किन इतनी ज्यादा सीवियरली डैमेज होती थी कि यू आर गेटिंग सम वेरी डैमेज्ड स्किन, और ऐसा लगता था जैसे कोई वुल्फ बाइट हुआ है। और तो शुरू में इसको लूपस बोला गया। फिर बाद में पता चला इसमें फीवर भी आते हैं, इसमें इंटरनल ऑर्गन भी इन्वॉल्व होते हैं, तो इसमें फिर सिस्टमिक वर्ड जोड़ा गया। तो फाइनल कंक्लूजन है सिस्टमिक लूपस एरिथेमेटोसिस। अब ये जैसे एचआईवी होता है, एचआईवी इज अ डिसीज, एक कंडीशन है, और एड्स इज अ एक मैनिफेस्टेशन है। तो ऐसे ही एसएलई में भी बहुत डिफरेंट मैनिफेस्टेशन होते हैं। एसएलई शुरुआत हो सकता है बहुत माइनर फॉर्म पे आए, हो सकता है बहुत सीवियर फॉर्म पे आए, हो सकता है माइनर फॉर्म पे आई हो बाद में सीवियर में कन्वर्ट हो जाए, हो सकता है बहुत सीवियर फॉर्म पे आई हो बहुत लंबे समय तक माइनर फॉर्म पे चली जाए। तो बहुत डिफरेंट टाइप से एसएलई प्रेजेंट करती है। ओके, सो लेट्स क्रिएट अवेयरनेस अबाउट लूपस। तो दिस इज माय फर्स्ट स्लाइड। सो व्हाट इज लूपस? सो लूपस या एसएलई इज अ ऑटोइम्यून डिसीज। आपका प्रतिरोधक तंत्र आपके शरीर के खिलाफ काम करता है। इट्स अ क्रोनिक प्रॉब्लम। लोग बोलते हैं कि एसएलई हो गया है तो ठीक हो जाएगा। नहीं, ये क्रोनिक प्रॉब्लम है, ये लंबी प्रॉब्लम है, ये एक आप इसका ट्रीटमेंट है, हम इसको असाध्य रोग अब नहीं बोल सकते, साध्य है, लेकिन ये क्रोनिक प्रॉब्लम, एक लंबी प्रॉब्लम है, आप जो आपके साथ लंबे समय तक रहता है। तो एसएलई इज अ क्रोनिक ऑटोइम्यून डिसीज। इम्यून सिस्टम इसमें बहुत तेज है। ये कोई और जिसमें आपका इम्यून सिस्टम आपकी बॉडी को अटैक करता है। चूंकि एसएलई में स्किन वगैरह इन्वॉल्व होती है, तो कई लोग इसको क्या बोलते हैं, माता आ गई या चिकन पॉक्स हो गया और डिफरेंट काइंड ऑफ कंडीशंस में, तो उन लोग पेशेंट्स दूरी भी बनाने लगते हैं और इससे डॉक्टर्स के पास पहुंचने में टाइम भी लगता है। तो ये कंटेजियस नहीं है। एसएलई कोई कम्युनिकेबल प्रॉब्लम नहीं है कि एक पेशेंट से दूसरे पेशेंट को पहुंचेगी, क्योंकि ये कोई इन्फेक्शन से नहीं फैल रही है, ये आपके शरीर से उत्पन्न हो रही है। दूसरा, एसएलई जो है स्किन बहुत गंदी दिखने लग सकती है, हो सकता है इंटरनल ऑर्गन हो बहुत वीक होने लगे, ये कैंसर नहीं है, बट इट कैन कन्वर्ट इट, इट्स अ प्री कैंसरस कंडीशन। ऐसा नहीं है कि अगर कंट्रोल ना हो तो कैंसर में कन्वर्ट हो सकती है, पर उससे पहले ये और डेंजरस हो सकती है और ट्रीटमेंट ना करें। एसएलई में अगर अर्ली डायग्नोसिस कर ले तो एसएलई हालांकि बहुत डेंजरस प्रॉब्लम है, लेकिन इसमें अपन ऑर्गन डैमेज को बचा सकते हैं, जो प्रॉपर ट्रीटमेंट के हिसाब से होता है। तो एसएलई में क्या होता है, स्किन इन्वॉल्वमेंट। क्यों? बॉडी का लार्जेस्ट ऑर्गन क्या है? स्किन। सो ऑब्वियस सी बात है, इम्यून सिस्टम और बॉडी का फर्स्ट डिफेंस क्या है? दैट इज स्किन। तो स्किन इन्वॉल्वमेंट इज देयर। देन जॉइंट्स की बात आती है, साइनोवियम। साइनोवियम एक फ्री फ्लो कंडीशन है, जिसमें न्यूट्रिशन पाने के लिए ब्लड से, सर्कुलेशन से चीजें आती हैं। तो कभी भी ऑटो इम्यूनिटी होगी या इन्फेक्शन होगा तो जॉइंट इन्वॉल्व हो सकते हैं। इवन सिंपल वायरल फीवर कैन लीड्स टू द जॉइंट पेन। सो एक्चुअली कैन लीड्स टू द सिंपल जॉइंट पेन टू द वेरी सीवियर जॉइंट पेन्स आल्सो। सेम स्किन प्रॉब्लम लाइक दैट। देन डिफरेंट ब्लड साइटोपिनियाज, डिफरेंट अलग अलग, कभी प्लेटलेट कम आ रहे हैं, कभी डब्ल्यूबीसी कम आ रहे हैं, कभी हीमोग्लोबिन कम आ रहा है, डिस्पाइट ऑफ आयरन रिप्लेसमेंट। बहुत सारी प्रॉब्लम के साथ भी ये सब कंट्रोल नहीं हो रहा है। देन सीवियर ऑर्गन में एसएलई कैन इन्वॉल्व योर important organs like brain, lungs, heart, kidney, everything. So this is SLE. So SLE is a multi-system disorder. Okay, it's a chronic disorder. SLE doesn't mean always severe. SLE doesn't mean always simple or mild. SLE can be anything. Course of SLE can be very different. So SLE is a very heterogeneous disease which will behave differently in a different person. So each person's SLE is different. अगर आप लूपस के मरीज हैं तो हर व्यक्ति का लूपस अलग तरीके से होता है। ओके, so slide number 2, what is SLE? Second, same things are there. Autoimmune disease, आपके organ system involve होते हैं. I have discussed this. So key message is lupus is called disease of many faces. कोई पेशेंट को केवल फीवर हो रहा है, कोई पेशेंट को केवल एनीमिया हो रहा है, कोई पेशेंट को केवल जॉइंट पेन हो रहा है, कोई पेशेंट को स्किन प्रॉब्लम हो रही है, कोई पेशेंट को अनएक्सप्लेन किडनी फेलियर हो गया है, कोई पेशेंट को अनएक्सप्लेन लंग प्रॉब्लम हो रही है, और मिक्सर ऑफ ऑल प्रॉब्लम्स हो रही है, इवन इन यंगर एज ग्रुप में हो रही है। तो ऑल दिस कैन बी एसएलई, कैन बी एनीथिंग, but that doesn't mean कि everything is SLE. Okay, so SLE is the diagnosis of exclusion at superficial level. So usually what is a patient profile? SLE का patient क्या होता है? This is important part. SLE is not only a chronic problem. SLE केवल क्रोनिक प्रॉब्लम नहीं है, SLE उस एज ग्रुप को इम्पैक्ट कर डालती है जहां से पूरी फैमिली स्टार्ट होती है। मींस यंग रिप्रोडक्टिव एज ग्रुप फीमेल, मोस्टली यंग वुमेन्स होती हैं, स्कूल गोइंग, कॉलेज गोइंग, लेट स्कूल गोइंग, कॉलेज गोइंग, जॉब में, इन सब में SLE करता है। कॉमन एज ग्रुप इज 15 to 45 years. It can affect both extremes also, children also और ओल्ड एज ऑल्सो। इसका मतलब ये नहीं कि ओल्ड एज में मेनोपॉज के बाद एसएलई नहीं हो सकता, बट एसएलई मोस्टली इन रिप्रोडक्टिव एज ग्रुप। रिस्क फैक्टर क्या है, क्यों मेरे को एसएलई क्यों हो रहा है? फीमेल्स, कुछ जेनेटिक टेंडेंसी है। जेनेटिक टेंडेंसी डजंट मीन कि इट ऑलवेज गो इन अ फैमिली, ऐसा नहीं कि जाएगा ही। आपको कोई सेकेंड हिट चाहिए होता है, सच एज एनवायरमेंट, वायरल ट्रिगर, अल्ट्रावायलेट रेस सन एक्सपोजर बहुत इंपॉर्टेंट है। तो ये सब एक्सएलई ट्रिगर कर सकता है, इवन स्ट्रेस। सो जेनेटिक फीचर्स होते हैं, हार्मोनल इन्फ्लुएंस, जो फीमेल हार्मोन्स होते हैं, एस्ट्रोजन, प्रोजेस्टेरोन, स्पेशली एस्ट्रोजन, वो इम्यून सिस्टम को अच्छा रेगुलेट करते हैं। रेगुलेट नहीं, इम्यून सिस्टम को स्टिमुलेट कर सकते हैं, तो फीमेल्स में ज्यादा होता है। बाकी सन एक्सपोजर दैट कैन लीड्स टू द एसएलई, ट्रीटमेंट में भी इसका इंपॉर्टेंट है। स्मोकिंग एसएलई, देन इन्फेक्शंस, वायरल इन्फेक्शन एसएलई ट्रिगर कर सकते हैं। क्यों? वायरल इन्फेक्शन हुआ, इम्यूनिटी ट्रिगर हुई, वो इम्यूनिटी ऑटो इम्यूनिटी में तब्दील हो गई, देन इट लीड्स टू द एसएलई। देन स्ट्रेस कैन ऑल्सो लीड्स टू एसएलई, क्योंकि न्यूरो इन्फ्लामेटरी पाथवेज ऑल्सो होते हैं ना। देन what happens actually in SLE? Normally, suppose these are the cells. ये different cells हैं. Suppose these are the some immune cells. Immune cells को WBC कहते हैं, common patients language में, या white blood cells. तो ये body के soldiers होते हैं. ये कोई pathogen हो गया, उससे fight करते हैं. That is normal part. But suppose your immune system it starts firing your own tissue through different mechanism. That leads to the autoimmunity. So normally immune system is ready to fight any foreign infection such as COVID. COVID 2019 से पहले different forms में COVID virus होता था, तो this was very new virus, but still कई लोग बच गए, means बिना वैक्सीन के भी बच गए, तो their body was ready to fight that unknown antigen. So body can recognize any foreign antigen. That's its beauty. But problem is that कि ये अगर if there is a lots of opportunity, lots of options are there, so it can trigger against yourself also. So that pathway means you are creating abundance of variation. एकदम डाइवर्सिटी हो रही है, उस डाइवर्सिटी में सेल्फ के अगेंस्ट क्यों अटैक नहीं हो रहा है? क्योंकि वहां टॉलरेंस है, टॉलरेंस के डिफरेंट टायर्स होते हैं, दैट इज नॉट टुडेस टॉपिक, बट वो टॉलरेंस लॉस होता है। क्यों लॉस होता है? ड्यू टू सम जेनेटिक मेकअप, ड्यू टू सम अल्ट्रावायलेट रेज, स्मोकिंग, स्ट्रेस, सेक्स हार्मोन्स, वहां से इम्यून सिस्टम ऑन होता है। देन एक्वायर्ड इम्यून सिस्टम में क्या होता है? जैसे इंटरफेरॉन्स वगैरह हो गए, दैट इज एंटीवायरल सब्सटेंस, तो वो बॉडी में अननेसेसरली हाई भी है, एंटीबॉडीज बन गए हैं अगेंस्ट व्हाट? अगेंस्ट एंटी न्यूक्लियर एंटीजन। व्हाट इज न्यूक्लियर एंटीजन? डीएनए आरएनए। वी ऑल हैव डीएनए आरएनए, but we all will be agree that DNA RNA are inside the nucleus, that is not inside the blood. So body has never seen DNA RNA as a self. Whenever they see DNA RNA, this DNA RNA was viral or maybe bacterial, because viral was either DNA or RNA. So whenever say their naked DNA RNA with modification or some non-modification, it seems to be danger for them. So in SLE, somehow this nuclear antigen released in the blood system, that becomes the problematic, and that antigens created this immune system fires against this antigen, then all the problem starts. This is the beginning of SLE. Okay. So body defense army becomes confused. Why? Because tolerance is not there. So attack its own citizen. So किस लेवल पे उस कंफ्यूजन को दूर कर सकते हैं क्या अपन? तो that is a working part. CAR T therapy वगैरह वहां चल रही है, there वो हम क्योर देखना चाहते हैं. Then how this immune system attacking our body, हम वहां से इस ट्रीटमेंट को कंट्रोल करते हैं. Okay. So same thing what I told you. Suppose this is some DNA RNA. This is some antigen presenting cell. What is antigen presenting cell? It's like a simple police which is presenting towards the court. So antigen presenting cell presented to the court, that is a T cell. Then T cell converted into different form, different machinery, TH1, TH2, that's not a part. Then they created this antibody, or they helped to B cell and create this antibody. That is one part. Then this antibody can bind to the antigen. Once antibody binds to the antigen, the cascade of reaction starts. How? Because antigen antibody complex is not for our body. Our body saw it as a foreign or something bad happening. So they can read it off through opsonization, means engulfing it out, or through activating through other complement system. That is complement mediated toxicity, because antigen antibody complex either goes inside the cell, digest over, or antigen antibody complex, because suppose this is virus, suppose this one is some pathogen, this antigen is foreign, this antibody binds here, so antibody becomes activated, they attract the complement, then this complement goes and insert the pore inside the bacteria. So second method is a complement mediated cytotoxicity, means through the complement we kill some cell which has that foreign pathogen, or in case some autoantigen also. Okay. Then third part, suppose this and again this through this antigen antibody binds, antibody becomes activated. They, because natural killer cells have FC gamma receptor. What is FC gamma receptor? Antibody has two parts. Fab, that is the antigen recognition part, then FC portion. That is a basic part. Usually that part is silent. Whenever antibody binds to its antigen through Fab, FC portion become activated, and that activated parts become the ligand for a receptor. That receptor is known as FC, that is a fraction of crystallization. Gamma means IgG receptor. So natural killer cells has a receptor for IgG antibody. What IgG antibody? Not antibody against the immune complex IgG. Okay. So in this pathway, your cells becomes activated and these cells start secreting gray enzymes, lysozymes, different proteolytic enzymes. They kills the pathogen. So this is called as ADCC, antibody dependent, because antibody was their cytotoxicity. This was second number was CDC, complement dependent cytotoxicity. Okay. Fourth, this antibody can be, it's not binding to any antigen. Suppose this antibody, obviously this is a protein that fixed to some receptor and it blocks that some receptor and it stop happening some action, like myasthenia gravis. In myasthenia gravis, we have an acetylcholine receptor antibody. That antibody is not creating any damage or to the tissue. That antibody bind to the receptor and it stops in receptor's function. That is functional block. So one is ADCC, antibody dependent cytotoxicity. One is CDC, a complement dependent cytotoxicity. One is opsonization, that is a clearance, normal mechanism. One is a receptor decay or blockage of a receptor. Okay, so all these mechanisms are happening in SLE because SLE is the prototype type of autoimmune disease. Then same thing here, like this way, na? Let's go little bit ahead. I will explain it little bit in further slides. Like this. Suppose this antibody is here. So what is the fate of this antibody? Definitely nothing is there, either receptor blocking or immune complex. Suppose there is an immune complex and your antibody is fixed, means your antibody is fixed on the cell and antigen come. Then antigen binds to the fixed antibody which was fixed on the cell, then cell becomes activated, then degranulation. What is this example? This example is anaphylaxis. In the mast cell, IgE is already there. How IgE created? First, patient goes to the some garden. He received some pollen. He developed antibody. That antibody was IgE. That time patient doesn't develop any symptoms. Only antibody developed. That was first reaction. Then antibody went or goes inside and sit on the mast cell. Then second time when he went, again the pollen grain came. Then it binds to the mast cell's antibody directly. Here, this pollen grain is coming and binding to this antibody. Okay, that leads to the degranulation. That leads to the urticaria or mast lesions. So in SLE, whenever patients have itchy urticarial lesion, that is type 1 hypersensitivity reaction. Okay, because this mast cell is a sentinel cell. They can present in anywhere. So obviously in the small vessels. So in small vessels, this mast cell become activated. They created small vessel vasculitis, that is urticarial vasculitis. Why? Because type 1 hypersensitivity reaction occur. Why? Because immune complex formed. Okay. Then second, suppose antibody formed against fixed antigen. First example was fixed antibody. Now second example is fixed antigen. Suppose antibody formed against fixed antigen. What fixed antigen? Obviously, any fixed antigen in our natural body is a natural thing. That is not pathological. Suppose RBC. RBC has a RBC antigen. That is normal. But suppose antibody developed against RBC antigen. So antigen is fixed on the RBC. And antibody will come and bind to this fixed antibody, antigen. And that will create a problem, local problem. Means autoimmune hemolytic anemia. Means peripheral neuropathy because neurons has antigen. Okay. So this is called type 2 hypersensitivity reaction. Type 2 hypersensitivity reaction means immune complex is there, but it is localized. But problem was there, this time antigen was fixed. Type 1 hypersensitivity reaction, immune complex was there. That was also localized. but that time antibody was fixed. Third is immune type 3 hypersensitivity reaction is here. Your antigen or antibody complex developed inside the blood vessel. They are not stabilized or localized anywhere. Now they are circulating. Now, while circulating, they will go to the different organ where filtration occurs, like blood-brain barrier. So they develop neuropsychiatric SLE. Like glomerulus, they developed glomerulonephritis. Like blood vessels, base of the blood vessels, they developed vasculitis. So this is a type 3 hypersensitivity reaction. So SLE is type 1 hypersensitivity reaction, SLE is type 2 hypersensitivity reaction, SLE is type 3 hypersensitivity reaction. Suppose type 1 hypersensitivity reaction is there. Only steroid and some antihistamine is sufficient. Suppose type 2 hypersensitivity reaction. Antigen was normal. You can't eliminate antigen, but you have to eliminate the antibody. That's why rituximab IVIG can work. So IVIG and rituximab works very well in autoimmune hemolytic anemia and peripheral neuropathy. Why? This is a reason. Because that was type 2 hypersensitivity reaction. Okay. Type 3 hypersensitivity reaction is circulating in the complex. So everything becomes activated. So it's need either combined immunosuppression or very aggressive immunosuppression. So non-selective. You understand? Both humoral, both cytotoxic, both part. So this was the pathogenesis. Okay. And another part, because in that immune system, this is, I told you, what is virus? Virus is a virus is nothing. It's a nuclear material. Either DNA or RNA with protein capsule. That is virus. What is bacteria or something? It's nuclear envelope, although not very developed, DNA, RNA, everything machinery. But virus has either DNA or RNA. So what is antiviral protein? Antiviral protein is a interferon. So this pathway is interferon, type 3 hypersensitivity reaction. So interferon can lead to the different skin manifestations or different manifestations. Like simply you can say in antiviral fever, like chikungunya, you have skin manifestations. In parvovirus, in different viral diseases, slap check disease, chick disease. So SLE has, due to interferon, they have different skin problems. Due to type 1 hypersensitivity, different problem. Due to type 2 hypersensitivity, different problem. Due to type 3 hypersensitivity, different problem. Okay. And last thing is due to inflammatory meluli. Constantly there is IL-1, IL-6, TNF-alpha. Continuously it is there. So patient is having constitutional symptoms like fever, fatigue. And because of this inflammatory meluli, your neurons, peripheral neurons, like pain receptors, they becomes activated. They are unnecessarily having small fiber neuropathy. That is not picking up in NCS, nerve conduction study, that is there. But every time nerve conduction study is normal because long fiber is not affected, only small fiber. Why small fiber is affected? Because of these inflammatory molecules. Okay, understand? So this is there. What is apoptosis? Apoptosis is a programmed cell death, correct? So why programmed cell death? Because body wants to kill those cells without exposing DNA, RNA or intracellular material outside. So suppose apoptosis is defective, your intracellular material is outside. That intracellular material becomes neoantigen. That neoantigen is activate your immune cells and your innate receptors. That activate your interferons. That activates your JAK-STAT pathway. That activates your T cell, which activates your B cell. B cell activates different growth factor. Different growth factor leads to different antibodies, immune complexes, netosis. All these are things are there, and the different targets are there. Okay. So as I explained, now we will go very fast because inflammatory system was their environment. So fatigue, fever. So SLE is one of the reason of the pyrexia of unknown origin. Persistent fever is there. There is no infection. God knows what is there. It could be SLE. Okay, that is one point. Then different skin manifestations. Not only butterfly rashes, different type rashes, permanent rashes, transient rashes. All these are photosensitive or without photosensitive. What is photosensitive? Whenever you go outside in the sunlight like this way, so sunlight trigger this problem. Usually your face areas are exposed in the sunlight. So this time the rashes occur. So this part exposed. So all these rashes occur. Alopecia, you start having hair loss. Different oral ulcers, hair loss in the patches with scarring. So all this is known as acute subacute, chronic, all these things are there. So sunlight is a problem. So sun protection is a solution. So cap, umbrella, sunscreen, all these are advised in the treatment. Okay. Then kidney problem. I told you immune complex circulated, went to the kidney, and in kidney it involves to the glomerulus. Now glomerulus has different part. We have some blood vessel, then some filter. How the filter develop? Filter develop with mesenterium, correct? With endothelium, with basement membrane, then urine. So break it down like that. Blood, okay, then mesenterium, then endothelium, then basement membrane, then urine. So blood will collect upside somewhere. We don't know nothing where. So it's minimal change disease. Suppose blood is collect first in the mesenterium. It's a mesenterial problem. Suppose blood is collected in the endothelium. Endothelium means everything filtration barrier went. So endothelium went, so means clogging is there. So clogging is there, lots of infiltration, RBC, RBC. So hematuria is there, clogging is there. That's why some proteinuria is there. That's why hypertension is there. That is known as proliferative glomerulonephritis. So if it involves less than 50%, it is known as focal glomerulonephritis. If more than 50%, diffuse glomerulonephritis. Suppose it crosses the basement membrane and reach to the podocyte, epithelium. That is meant for only for the protein repulsion. What is the filtration barrier? Endothelium, basement membrane, then epithelium. Epithelium is negatively charged, that is for the repulsion of the albumin. So suppose immune complex not deposited in mesenterium, in endothelium, that directly shipped off because of the small immune complex direct to the last part. So only proteinuria is there, massive proteinuria, severe nephrotic syndrome, that is known as membranous nephropathy. Last part, permanent kidney failure. So on the basis of the deposition of the immune complex, clinical manifestation is different. One is silent, one is minimal mesangial, not very problematic. One is very problematic, that is proliferative. One is protein losing. Okay. So once you lose the protein, you will have a swelling. Okay. Your urine become frothy. Correct? Then because clogging was there, kidney is sensing no blood. Kidney is thinking kidney was devoid of blood. So renin secretion was there, hypertension. Then urine output could be low, could be high. Okay, so this is there. Important point, SLE, every SLE patient should be screened for the kidney because they can have silent kidney disease. I told you, the position is above side. You will not pick it up. Okay. So this is what I told you. Mesangial, a different compartment. Then you can involve the tubular problem. This is tubule. So tubular problem, different concentration occur the tubule. Suppose tubule is problematic, definitely kidney failure, but diluted urine. Suppose glomerulus is involved, so concentrated urine because filtration is not occurring. But suppose tubule is problematic, filtration is occurring, but concentration is not occurring. So one is oligouric kidney failure, one is polyuric kidney failure. You got my point? So both way, through the urine output, you can't judge there is a kidney problem or no. That then blood vessel, which is important for the blood supply to the kidney, can be hampered in this problem. Okay, this is kidney problem. Then blood. I told you antibody developed against the RBC, anemia. That is one. Second, for iron absorption, we need a silent medium. I will not go to further details. Suppose continuously inflammation is there, then the iron absorption in cooperation with RBC will not occur. That is known as anemia due to chronic disease. That is second anemia. Third, suppose kidney is not working. Erythropoietin is secreted by kidney. So renal related anemia. That is third anemia. Suppose you have an antibody against the parietal cell, which is forming the intrinsic factor, which is important for B12 absorption. So you have a B12 deficiency anemia. Suppose you develop some celiac disease, some chronic blood loss. So you have iron deficiency anemia. Suppose you develop antibody against the bone marrow, or because of the inflammation, bone marrow is not properly functioning. You have a hyperproliferative anemia. So you will have anemia, but etiologies are different. That's why treatment is also different. Huh? Leukopenia, same way, through bone marrow suppression or directly killing. Platelet, unexplained thrombocytopenias. Okay. So suppose hemolysis is there, that is a dangerous problem. RBC is broken down into the blood circulation. तो आरबीसी ब्रोक डाउन, तो मेम्ब्रेन ब्रोक डाउन, तो और लिपिड मॉलिक्यूल्स formed there. So and hemoglobin broke down. So hemoglobin will broke down into the bilirubin. That is the jaundice part. So patient is having mild jaundice with anemia with dark color urine. That is autoimmune hemolytic anemia, and that is a very dangerous condition because you will have different kind of kidney failure through this free iron or free hemoglobin. So another mechanism of kidney failure. Okay. Then you have hypercoagulable state. Although inflammation itself a hypercoagulable state, because why have you created inflammation? To eliminate the pathogen. So what will you do? You will create an inflammation, you will create a clotting state. So you can trap the pathogen. Same thing happens in any inflammatory condition. So any inflammatory condition leads to the hyperthrombotic state. But another condition that is known as anti-phospholipid antibody syndrome, that is a hypercoagulable state, that is also happening in 1/3 cases of the SLE, that can lead to different clot. That different clot leads to different recurrent miscarriage, deep vein thrombosis, heart attack, stroke, young stroke, all those things. Okay. So this is there. Hematological complications I have explained. Then mental health. Patient is having chronic problem. Patient is in a reproductive age group, young age group. So patient can have anxiety, depression, fear, different isolation problem. But SLE itself, I told you, it can impact your brain. Okay. So SLE, NPSLE is a different syndrome. We have 17 different kind of brain problem in which you have stroke, seizures, anxiety, depression, Alzheimer-like disease mechanism, antibody mediated direct neuronal injury that leads to the peripheral neuropathy. That is type 2 hypersensitivity reaction. The rituximab will work. Blood-brain barrier will become leaky. Usually your brain don't have immune cell. This is an immune privileged area. Your eyes and brain don't have immune cell because this could be very risky if you have immune cells inside your brain. But in SLE, your this filter becomes leaky. So your immune cells can enter inside your brain and that create a severe problem. Okay. Then different, I told you different cytokines, they can itself create a different psychiatric problems. Then immune complex, suppose immune complex is there, then complement can activate it, can have a problem. So different SLE has a problem. So this side broad syndrome, thrombotic, unnecessarily clot हो रहे हैं, antibody mediated, कोई पार्ट ऑफ ब्रेन काम नहीं कर रहा है या पेरिफेरल न्यूरोपैथी हो रही है, पार्ट ऑफ ब्रेन काम नहीं कर रहा तो साइकोसिस, कॉग्निशन, मूड डिसऑर्डर हो रहे हैं. देन साइटोकाइन की वजह से ब्रेन फॉग हो रहा है, फीवर आ रहा है, फैटिगेबिलिटी हो रही है. देन ब्लड ब्रेन बैरियर अगर परमेबल हो गया तो डिफ्यूज फीचर्स आएंगे. पेशेंट कैन गो टू स्ट्रोक लाइक फीचर ऑल्सो. माइलिन शीट के खिलाफ एंटीबॉडी बन सकती है. सो ऑल दीज आर देयर. So once again, integrated approach. This is important for the medical students. Antibody, then antibody cytokine complement. So three things: through antibody mediated injury, through complement mediated injury, through cytokine mediated injury, through permeability mediated injury. So we have four mechanisms in which your brain can involve. So we can block all the four mechanisms. Okay. So these are the there. Then how we conclude this patient has SLE? Obviously history. This is very heterogeneous problem. Unexplained anemia, urinary problem, different things are there. But these are the important tests: ANA, dsDNA, C3, C4, CBC, anemias. So these are the ANA. ANA means anti-nuclear antibody. Now it has been gone way up, but how to interpret it? One is a titer. The titer is high. The positive predictably chances of getting is SLE is high. Titer is high, that doesn't mean severe SLE. Titer is low doesn't mean low SLE. High titer means probability of getting disease is high. That is one titer. Then pattern. Pattern, how pattern? Because we know nucleus. Nucleus is made up of nucleosome plus RNA. Nucleosome is everywhere. What is nucleosome? DNA histone. RNA is everywhere. So suppose nucleosome antibodies against the nucleosome or histone or DNA. It will cover all the nucleus. So it's a homogeneous pattern. Either of this. Suppose RNA antibody is there. It will pick here and there, here and there, here and there. So it's a speckled pattern. Very simple. What is the largest organelle of nucleus? That is nucleoli. That involves spliceosome. That is a different matter. But nucleoli is the largest one. Suppose you see 3 or 4 dots in ANA pattern. That is a nucleolar pattern. So 3 patterns. Suppose whole nucleus is stained. It means either DNA or histone or nucleosome. Suppose only sparkling like this. This is a speckled pattern here. Only here dot 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 something is involving like this. This is homogeneous pattern. Everything is involved. So what is the target antigen? DNA, histone. Third, I told you, nucleosome. Speckled pattern. What is this? This is RNA. What is RNA? RNA or ribonucleoprotein. What is protein? This protein could be Smith. Here itself, RNP means ribonucleoprotein. This could be Rho. This could be RLA. This is second pattern. Third pattern is nucleolar. I told you largest organelle. How much? 3 to 5. 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Nucleolar pattern. That is necessary. Then DNA is dividing through centromere. So centromere, we have 46 chromosomes. So how many centromere we have? 96, because they are dividing. So if we have that 96 dots, so that is a centromere pattern. So this is simplest way. This is immunofluorescence. We are not telling you this is DNA or RNA or histone. We are telling this could be either DNA or histone. This could be either RNA or RNA protein. This could be nuclear protein, this one or that one. Okay. So to get the exact antigen, we have LIA, because each antigen has different values. So in LIA, we have different antibodies, in which Smith antibody, I will not confuse you, but all these whatever written here, that is related to different manifestation to the different antigens. So first thing is screening. What we are seeing the pattern. What pattern will give a clue whether what kind of CTD this could be. Then there is a titer. High titer means high positive predictive value, no severity. Then intensity. Intensity means how much green. How apple green? What is the color of apple, Ankit? Have you seen green apple?
Yes, sir. When it's unripened. So
These foreign writers, they
yes,
chose
sir.
the word green apple. Okay, because
Green
of this
apple.
green color, they can choose only
Yes.
green only. Na? So on the basis of the intensity of the green, that's why green refrigerant, that's what called. No? They are giving the intensity 1 plus 2 plus 3 plus 4 plus. That is also positive predictive value. Or intensity is for more reproducibility. Suppose intensity is very high. So what I am saying, you will go to see also same kind chances is there. So all these is screening. Confirmatory is this, not confirmatory, target antigen is this one. No? Then we have how we measure the SLE activity through different score, that is known as SLEDI score, वगैरह वगैरह. Then we are basically checking kidney, liver, blood, urine, ASR, CRP. Then ANA by IF method. I am not telling ELISA. And ANA by LIA method. Anti-dsDNA by ELISA method. Why I am telling all these methods are different and these have very important significance. But whatever in the public domain is happening, they are coming with a different methods to different things. That is not going to help us, and patient has to pay double and triple. So they are thinking why this person is asking again and again for the new investigation, because scientifically they are very different. So I wrote here this is a IFA method. Then LIA I told you there for the antigen. Then for the DNA, because DNA is correlating with the disease activity. So suppose DNA is high. Suppose you will get an answer DNA is plus or minus. You will be in a dilemma. What it means? But you need DNA is high, medium, or low. So you need a titer. So through ELISA, you can get an anti-DS DNA titer. So suppose this is more than 100, that is active. Suppose it is more than 500. With the treatment, it comes down at 400 or 200. So it has little bit significance. Then complement. I told you immune complex. They will go through CDC, complement dependent cytotoxicity. So that means complement consume that immune complex. So C3, C4 means suppose C3, C4 is very low. That means immune complex burden was very high. Because complement was clearing those immune complex. So C3, C4 is important. That DCT is a direct comp test. That's a type 2 hypersensitivity reaction. Okay, then chest X-ray for pleural effusion, fluid inside your lungs, outside your heart, to pleural effusion, 2D go, functional MRI for the neuropsychiatric SLE. Okay. Then living with SLE, simple. Be in touch in your with your doctors. Be in regular medicine because these are the chronic diseases. Don't stop in between. Most of the time, reason of the flare is a non-compliance of the patient. Most of the patient is asking for the diet. It's a balanced diet, nothing more than that. Debate on the diet is okay, but it's not that important. Is sun protection, regular medicine, avoidance of the smoking, stress reduction. SLE patient can simply many of the my patients of SLE, they got very good degrees, married, even children also. So marriage is also possible, life is also possible. So sunscreen, caps and umbrella and full sleeve cloths. It's better not to wear very dark clothes. Treatment, different parts. So different agents are there. All these things I'm not going to in detail, but for the patient's sake and for the JRs also, hydroxychloroquine is quite essential drug for SLE. Until unless it is contraindicated, you have to use hydroxychloroquine because it prevent the flare. That is not very aggressive immunosuppression, but it is a cornerstone of the treatment, part of the treatment. So never miss hydroxychloroquine. All other drugs are there, but this is the this is a method assess disease activity. Suppose disease activity is very high, so we will choose the higher immunosuppression. Suppose disease activity is medium, we will choose a medium immunosuppression. Then monitor the disease. Okay, this is for the therapies. Although now there is a triple therapy, but these are the different regimes used for the treatment of the kidney problem, non-renal problem. Okay, myth again, this is not infectious disease, ये communicable disease नहीं है. ये SLE केवल स्किन की प्रॉब्लम नहीं है, इट्स अ मल्टी सिस्टम डिसऑर्डर एंड वेरी सीवियर मल्टी सिस्टम डिसऑर्डर. SLE doesn't mean life is over. SLE में आप नॉर्मल लाइफ जी सकते हैं. SLE doesn't mean कि you can't work, you can work. Early diagnosis definitely helps. When to meet your rheumatologist? Definitely once your primary physician send you, otherwise hair fall, recurrent mouth ulcer, recurrent miscarriage. See the domain. Recurrent miscarriage is also there. Hair fall is also there. No one think about the SLE. Na? Skin problem there. Some fever is there. So all the non-specific symptoms can be the SLE problem. So this is for the World Lupus Day tomorrow. So it's make lupus visible. And through this, I will conclude my slides.
Thank you so much, sir, for the great presentation.
Thank
Friends, yes, sir.
you. If you have
Uh,
any questions, we can.
yes, sir. So, friends, we have covered a lot just now. So, I am going to ask Dr. Tiwari few direct questions. I know today we have both general audience and medical professionals. So, some of these questions are for everyone, and some are specifically for our medical colleagues. Sir, are you ready?
100%.
Yes, sir. Let's go. So, sir, SLE is famously called great imitator. In your experience, how many doctor does have an average patient visit before finally receiving the correct diagnosis? And where does the breakdown happens from general physicians all the way to specialist?
Actually, this is a very good question also, and this is a problem also. Na? Right now, I'm working in a tertiary center. So somehow patient, because of the some here and there, because presentation is very different. Usually in our MD time or MBBS, we are thinking SLE will come with a rash or something. No, SLE is very different. Some patients are coming with only pleural effusion. Some are coming with only pericardial effusion. But obviously, this is any diseases. Are you can classify any disease like infectious disease, metabolic disease, autoimmune disease or cancer. So metabolic disease and cancer, autoimmune disease, cancer is coming very narrow down in the lower side. So we have to exclude first the common etiologies. So obviously patient got delayed for the diagnosis, but as the investigations becomes popular and easy accessible to the different places, we will get early diagnosis. Nowadays, I'm seeing quite good number of the patients, and my MD JRs also seeing a good number of the patients.
So this one is specifically for our medical colleagues watching today in a primary care or non-rheumatology setting. What is the one clinical sign or lab finding that one should immediately prompt or refer to rheumatologist? That single red flag that absolutely cannot be missed.
See, we can't say like that way because if I pinpoint something, no, because many skin problem masquerade towards the SLE. Once you think SLE, you will either refer or your attempt to give a higher dose of the steroid. So this is very difficult to say. कि, हाँ, definitely this is. But mostly up to 80% of the SLE patients have skin problems sometimes in their life. So you have to ask previous questions, uh, current questions. So HCL is a holistic approach. You can't judge like that way. Haan, definitely ANA is a screening method, but it should be done in a IF method, and doctor should be educated enough to interpret those things. So this is a problem in our setup because ANA reports are coming, but that is not appropriate.
So, friends, please note that down. That is a practical gold right now that Sir told us. Sir, something I hear very often from the patient and from their families, the fear of steroids. It will damage the body, weakens the bone. So, sir, how do you address this fear with your patient? And medically speaking, when are steroids truly necessary and when they are not?
एक्चुअली स्टेप ये है ना, जैसे वॉट एवर आई टोल्ड यू इनिशियली, सम टॉलरेंस खत्म हुआ, लॉस ऑफ टॉलरेंस, autoimmunity started, autoimmune system started with a different machinery, cells, antibodies, cytokines. Then some cells becomes overactivated, that releases lots of inflammatory enzymes and things and target organ damage. Okay, so hierarchy is like this way. First you have to stop all the burning fire. So you need a drug which can stop immediately all the burning fire from here to here. That is a steroid. So we are giving steroid to rescue the patient from that condition, because if you just rely on the immunosuppression will work here, some upside, some at cellular level, some cytokine level. Already lots of things are happening down the line. So first you have, suppose this is like a simple analogy. इस रूम पे आग लग गई और आग लगी बिकॉज ऑफ स्विच वाज नॉट वर्किंग, तो पहले आप आग बुझाओगे कि स्विच बंद करने जाओगे? You have to first stop your fire, then you have to intend in the loop, then stop the switch. So immunosuppression we have to stop immunosuppression simultaneously, but steroid is a rescue medicine. अगर steroid नहीं है तो this becomes sometimes it really becomes very difficult to rescue the patient. That is one. Second, unnecessarily use of steroid is a problem. Judicial steroid is a kind of boon or something, because you can rescue the patient. So it's about, you need a correct treatment, correct diagnosis, correct way. Okay. So steroid is not a problem. Problem could be the way it was prescribed. But steroid is not a problem. That is one. And we are not giving you steroid lifelong. That is second. Third, immunosuppression is not going to work acutely, immediately. It will take time, at least 2-3 months. So we have to give you steroid for the bridging period. So that you have to understand.
Sir, what has changed in SLE management over the last few years? The biologics like belimumab and anifrolumab are being talked about, and what is the current reality of access and affordability for the patient in India? And at what point should we be considering this newer options?
Belimumab is actually costly in India, is not really available. That is one. Okay. Anifrolumab is still not really available in India. That is two. Okay. One is because in the recent advance we have oclosporin. That is very good for the kidney. That is also not available in India quickly. So advancement is there, but everything is not available in India. That is one. Second, we were searching for the cure of SLE. There is a one therapy that is known as CAR T therapy, chimeric antigen T cell therapy. That is important. Oh, and that has showed completely clearance for the 4-5 years. But that is costly, but it will take time. But so gradually it will come on the normal practice and routinely. So we are doing good things in SLE. Right now in the Indian practice, we are lacking of some drugs, but soon we will go. We will get those drugs also, and you pharma people should arrange those things.
Everyone, this is the future of treatment, a very important update. So last question. Somewhere on this screen today, there is a lupus patient who's still searching for the answer, exhausted and afraid. And there is also a junior doctor facing a lupus SLE case for the first time. So what would you like to say to both of them directly?
Ear disease, that is one. So first we have to, if possible, try to refer to the rheumatologist. I'm seriously telling you, because it's not, it's a this is treatable problem. You can treat, and patient can, you can rescue the patient very well from the problem. And nowadays, every state somewhere they have rheumatologist, and some good tertiary centers are also there. You have to convince them and try to send them. In between, you can give randomly. I can't say that you can give on the basis of the judgmental basis. You can give this steroid or something, but you have to send them as early as possible and try to convince them not to go in different else somewhere else or some all those things, because these days we have rheumatologists in different states. So this is there. So I can't tell you have to give this or this. Just one thing I can tell you, see the checklist, SLE patient is getting HCQ or not. Ask the patient whether they are compliant with their prescribed medicine or not. Third, whether they are using the protective sunlight protective gears or not, like cap or umbrella or sunscreen. All these things is okay, but beyond that, we need the not expertise. We need some experience. And as these diseases are not very common, so we can do the mistake also to the patient. So it's wise to refer the patient to the rheumatologist as early as possible, or person who is practicing as a rheumatologist at least.
And for the patient,
For the patient need to understand this is a multi-system disorder. This is a disorder. They have to follow the. Suppose they are in the good shape. That doesn't mean every time this is going to be in a shame mode. Or second thing, it is not always lethal. So be in faith like a cardiologist. So because you are having a heart problem, definitely you are going to a cardiologist. You have some diabetes, you are going to endocrinologist. So go meet some rheumatologist. You need after some time you need once consultation in 3-4 months. That much we can control. So don't afraid of this disease, but don't take it casually and don't mix up all these drugs from your side.
sir, today you didn't just do, you didn't, I mean, this was not just a Facebook Live, sir. You have fulfilled the true responsibility of a doctor for the patient, for the families, and for your medical colleagues as well. So thank you so much, sir, from the bottom of my heart. Friends, for everyone in the general audience, remember just one thing: don't ignore your symptoms, see the right specialist. A normal life is possible. And for the medical professional who are watching today, just one request: the next SLE patient who talks through your door, be the one doctor who refer them correctly at the right time. That one decision can change everything for them. So thank you so much, sir. This was a
Thank you.
great presentation.
Thank you. Thank you. Thank you. Thank you. Okay, please create awareness towards the SLE for every viewers who are seeing. Tomorrow is SLE day. We are observing tomorrow as SLE day. So just create awareness, make SLE visible. Thank you. Namaskar.
Jai Hind.
Jai Hind. Jai Hind.